I am Amr Abdelftah, Assistant Lecturer of Internal Medicine, Helwan University. First of all, I'd like to thank all my professors and colleagues at our department for unlimited support and the conference board for the kind invitation. My case is titled From Vague Hematological Diagnosis to a Confirmed Liver Disease. An 18 years old female patient, single, from Helwan and university student at Helwan University with no special habits of medical importance. Her menstrual cycles are regular with no abnormalities. The patient came to the ER complaining of an attack of vomiting of blood that occurred 1 day before presentation. The condition started at the age of 15 when the patient had dyspnea on moderate exertion with gradual onset, stationary course, associated with easy fatigability and pallor, not associated with dyspnea or paroxysmal nocturnal dyspnea, orthopnea, chest pain, or any symptoms suggestive of a cardiac disease, or chest expectoration wheezes that suggest of a chest disease. No history of bleeding, jaundice, a change in stool or urine color that may suggest bleeding or hemolytic disorder. No history suggestive of any immunological disease or neoplastic etiology, bilharziasis, and no history suggestive of any infectious disease. She sought medical advice and investigations. In August 2021, revealed pancytopenia and splenomegaly in abdominal ultrasound. Despite not reaching a definite diagnosis, she was prescribed steroid therapy and was maintained for about 6 months. The patient was then instructed to stop steroid therapy by her treating hematologist and shifted into L-thrombobag, that is thrombobiotine. Further investigations were done in January 2024. Abdominal ultrasound revealed mild splenomegaly, 15.5 centimeter, bone marrow core biopsy that showed normocellular bone marrow with hyperactive megakaryopoiesis. The patient reported a history of stitching right upper quadrant pain that started 2 months before presentation with a progressive course over the preceding month. The pain severity was described by the patient as 5/10 and relieved by analgesics. It was not radiated and has no specific timing or relation to food. It is not associated with fever, nausea, vomiting, urinary symptoms, or altered bowel habits. 1 day before admission, the patient presented by 2 attacks of hematemesis. It was about 2 cups of dark brown blood containing some blood clots and associated with melena of 1 day. There was no associated syncope. The patient reported no preceding nausea, vomiting, dyspepsia, and no bleeding from any other body orifice. About past history, no history of diabetes or hypertension or any other chronic disease, no history of previous surgery or hospital admission, no history of previous blood transfusion, and no history of familiar similar attacks. Examination, the patient is fully conscious, alert and oriented to time, place, and persons, lying flat, average body measurements, BMI 22.5 kilogram per square meter. The patient looks pale, but no jaundice, no cyanosis, and all vital signs were normal. Head and neck examination revealed pallor in conjunctiva and inner lips. Upper limbs showed pallor in palmar crease and nail beds. Lower limbs, no edema and intact peripheral pulsations, and no lymph node enlargement, and the skin examination was normal. The abdomen was slightly distended with divercation of recti. Umbilicus is midway between the sternum and symphysis pubis. No abnormal discharge or visible dilated veins, with wide subcostal angle, and no hernial orifice or visible scars or pigmentations, and back examination was normal. With superficial palpation, no guarding, no rigidity, and no tenderness. Deep palpation showed splenomegaly felt reaching midline, non-tender, firm in consistency, with rounded edge and smooth surface. The splenic notch not felt. The percussion showed dull trops area and no ascites. Auscultation of the abdomen was normal. Chest and cardiac examination were normal. On admission, hemoglobin was 7.7, MCV 79 and MCH 23, low TLC count with 2.9, low platelet count 51,000, normal INR, normal liver enzymes, bilirubin level was normal, albumin normal, renal function test normal, and sodium and potassium normal. Ultrasonography showed that the most distal part of the portal vein showed aneurysmal dilatation with partially occluded right and left portal veins for CT assessment and splenomegaly of 21 centimeter. We do upper GI endoscopy that revealed fundal varices treated by histoacryl injection and esophageal varices that treated with band ligation later on. And the colonoscopy showed normal study. Then we go on autoimmune profile, thrombophilia profile, and liver profile. ANA was normal, anti-double-stranded DNA normal, lupus anticoagulant normal, anti-cardiolipin IgM and IgG for antiphospholipid syndrome normal, anti-mitochondrial antibody negative, C-ANCA and P-ANCA levels were normal, anti-smooth muscle antibody normal, liver kidney microsoma antibody normal, D-dimer slightly elevated, protein C and S normal levels, factor 5 mutation normal, prothrombin gene mutation negative. The patient has negative virology, and we do the workup for hemochromatosis or Wilson disease, serum ferritin 15, total IgG normal, 24-hour urinary copper normal level. This is a CT study showed that left hepatic loop and right hepatic loop showed intrahepatic irregular dilatations that is highly suspicious of sclerosing cholangitis. Right and left portal vein thrombosis and huge splenomegaly. And then we did MRCP for the patient that showed coarse liver, irregular dilatations of intrahepatic biliary radicals that is consistent with sclerosing cholangitis, and portal vein thrombosis, huge splenomegaly. So later on, the patient suffered low back pain. MRI sacroiliac joint was done, revealing narrowing of both sacroiliac joints, suggesting of bilateral sacroiliitis. Okay, this is a case of decompensated liver disease caused by primary sclerosing cholangitis and complicated by portal vein thrombosis and portal hypertension. To take home message, primary sclerosing cholangitis or BSC can be presented in a typical presentation. This case was no jaundice, no pruritus, normal liver enzymes, and also the patient was just only presented with hematemesis. Not all cases of BSC need a liver biopsy for diagnosis. This case was diagnosed by imaging. All patients with BSC should undergo colonoscopy for IBD screening. 2/3 of patients with BSC have IBD. Always search for other BSC-associated autoimmune disease. When we did the MRI, sacroiliac joint, we were searching for ankylosing spondylitis associated with BSC. Always manage acute event first, as we did. We manage hemostasis for GI bleeding. We do histoacryl injection for fundal varices. We do band ligation for esophageal varices in parallel with searching for the cause, and that was BSC. And finally, thank you all for attention.